I'm going to start by thanking the organizing committee for bringing me to this part of the world, and some of the members of the New York Presbyterian office here in Riyadh, that they organized my trip. Then, oh, too fast. The objectives are, we are going to review intestinal failure, the classification, and the management. I'm going to focus on the advances in medical management, basically the new lipids approach and the hormonal treatment, and some of the surgical management. Then what is intestinal failure? Then this is a condition when patients are incapable of maintaining proper nutrition through enteral intake. It's characterized by food intolerance, diarrhea, malabsorption, fluid and electrolyte imbalance, that is due to decrease of intestinal length or decreased absorptive capacity of this motility. And is usually the clinical presentation is poor growth in pediatric or weight loss in adults. And because one picture is 1,000 words, this is actually a Saudi national that came to us about 4 years ago. He was 18 months and his weight was less than 3 kilos. He has a condition called Tuftin enteropathy, and here is the picture of the condition. Then what is the etiology? I'm going to go briefly over this. On the right side, we have the most frequent causes of intestinal failure, where the intestine is short. Then these are the ones that are short bowel syndrome. You see one of these pictures through my lectures. You can see that I popped here and there. And on the left side are the etiologies, where the patient have a normal length of intestine, but the intestine doesn't work because it doesn't move, like in pseudo-obstruction, or they have some congenital diarrhea. For the majority part of this lecture, I'm going to focus on the management of the patient with short bowel syndrome. That is the ones that really can have can go on the rehabilitation. These are the etiologies of the patients that we take care of our hospital with that condition, similar to whatever you see in any other institution. What are the factors when you have a patient with intestinal rehabilitation in front of you and you want to predict how this patient will do in the next 10 years, 5 years, or 10 months? Usually you look at a patient and the first question is, can this patient be rehabilitated? Can this patient achieve enteral autonomy? And I think that age is very important. Why is that? We know that pediatric patients have better capacity to adapt. Also very preemie babies, when they are born and they lose significant part of their intestine, the intestine can still grow in length. Remember, the 3rd trimester of pregnancy, the intestine double in size. Then if you have a baby that is a 24-weeks old and have a major event necrotizing enterocolitis at 26 weeks, that intestine that is left inside still can grow significantly. If you have a patient that is a full term and develop volvulus and lose most of the intestine, then the length of that intestine might not grow much more. Then you have to be aware of that. Then the length of the intestine, how much intestine is left behind, is very important. But I also want to point that the overall function of this, the functional prognosis and complication associated with intestinal failure do not always strictly correlate with the length of the intestine. If you have a very long intestine, but that intestine has been damaged for certain reason, like for example, patient with necrotizing enterocolitis, the surgeon leaves a piece of intestine inside, but has been under ischemia or necrosis. It might not move, it might not absorb. Patient with gastroschisis, that first picture that you saw at the beginning of my lecture, that intestine that is exposed to amniotic fluid for many months, then that intestine might not move or might not work. Then be mindful of that. The anatomical site resected is always important. Jejunum versus ileum. I always said that the ileum is like that senior attendant that knows how to do everything and is very specialized, but don't do much because he's the senior attendant. But if you have this small fellow, growing, learning, hardworking fellow, maybe some fellows here in the audience, they know that they work very hard, but they are not very specialized. If they come to work and they don't have that attendant that guide them to do things that might not be able to perform. Though if the fellows don't show to work, the attendant can step up. This is the way that I see the intestine. The jejunum is hardworking, do almost everything, but not very specialized. The ileum doesn't do much. Whatever is left to do from the jejunum, maybe a little bit of absorption, but that is very specialized. The ileum is responsible for the absorption of the bile salts, is responsible for the production of very frequent hormones, most of the hormones that are involved in the intestinal rehabilitation. Then if you have a patient that you need to decide or make a prognosis whether they will be rehabilitated or not, the patient that have ileum might be more prone to rehabilitation than the patient that have only jejunum. And then the importance of the colons, we will talk about that in a few seconds. What is the physiological status of the remaining intestine is very important. You can have a lot of intestine, but if it doesn't work, it doesn't work. Then keep in mind about that. And the presence of ileocecal valve, many years we thought that this is important, and I have never been very interested in knowing whether the ileocecal valve is there or not. But what happened is ileocecal valve is a surrogate for the patient have terminal ileum and cecum. And the terminal ileum and the cecum are two very important biological organs for the intestinal rehabilitation. Most of the hormones involved in the adaptation are coming from that area. Then the valve itself is not important, but most patients that have the valve have both a piece of terminal ileum and cecum, and that is what is important. And what is the importance of the remaining colon? Then for many years we thought that the colon was just a storage facility. I really think this is a very nice study that was done looking at adult patients. Then here we presented that the fluid losses, I cannot get the pointer to work. The fluid losses are less if the colon is present. You see this is the amount of liter of fluids that the patient loses during the day. And on the bottom is the length of the small bowel. Then when the small bowel is really short, like here when there are only 50 centimeters of bowel, cannot get it to work, then the amount of the colon is very important. If the patient doesn't have any colon, they lose up to 5 liters of water a day. If the patient have the whole colon, they lose less than a liter a day. And also it's important the fecal energy losses. The more colon you have, is the better the absorption is. Then if you don't have a lot of small bowel, having the colon is very important. Then when I talk about nutritional management of this patient, I usually want to get organized in 3 phases. The phase 1 is the acute phase where patients are just very sick in the ICU and they are just undergoing kind of resuscitation. The second 2 is the second phase when the diarrhea reduction started. You can start feeding the patient. And then the phase 3 is that patient that came off TPN, it has total enteral autonomy, but that patient still should be a patient of a gastroenterologist because anything that happened to that intestine, even a small virus, a small diarrhea, that patient might need parenteral support. Then it's important to keep in mind that. Then this is the picture of our patient. This is how he came to us, and this is how he was 5 weeks after being on TPN. Then this is a picture that tells you that it could be acceptable and having a safe life on TPN. And all these pictures on the top are some pictures of some of the etiologies of short bowel syndrome. The problem is that, yeah, you can grow, you can live a long life, but the complication of the parenteral nutrition itself or the central line complications can kill the patient. Let's keep that in mind. The rest of the lecture, I'm going to focus on the stage 2, that is the adaptation phase. And I will be very happy here if I can tell you this is the route that you have to take from intestinal failure to intestinal anatomy. If you take this road, you will get there. Unfortunately, it's not like that. The road is more like a curve or sometimes a take back. And we take care of those patients. We know that sometimes you are making a lot of progress and you are very enthusiastic about how the patients are doing, and all of a sudden something happens and you cannot come to the intestinal autonomy anymore. Intestinal adaptation is the key for this. And then what is intestinal adaptation? Maybe many of you think that this is a fancy word that we have created, but in reality, these are structural and functional changes that happen in the intestine. The structural changes are hyperplasia, angiogenesis, bowel dilation, and bowel elongation. And this happens when the patient is undergoing intestinal adaptation. And there are functional changes. There are increase in the transports in the cells, and this is when the hormones that are secreted in the terminal ileum and the second take care of the intestinal adaptation. A slow transit time and increased nutrient and fluid absorption. When does this happen? This happens in the first few hours after the bowel is resected. Animals model has demonstrated that if you resect more than 50% of the bowel, these things start happening within about 48 hours and continue for months and years. We know that from our patients. The problem is if you don't feed the patient, the intestine don't adapt. If you just give TPN, don't expect that bowel to increase, don't expect anything to happen. Then you have to give some food to that intestine to adapt. Then I always think intestinal failure as a medical arm and a surgical management, and this is what is important, to have a multidisciplinary team to help you with the rehabilitation. The medical management usually focus on parenteral nutrition and growth factor, and the surgical management will focus on intestinal lengthening and intestinal transplant. Then you need a multidisciplinary team, and this is what I'm going to make my point here. You need gastroenterologists, surgeons, nutritionists, nurse, social workers, psychologists. These kids have a lot of problems. They cannot eat in public. They cannot sit at the table with the family because they don't eat regular food. Then medical management. This is what we do in our hospital. We optimize enteral feeds, and I think that this is the key for this. If anybody have an ostomy, we can restore that continuity. We try to bypass area of motility. Sometimes the stomach doesn't work, then you put a GJ tube. We use a lot of medication depending on the clinical indication. We try to cycle the TPN, decrease of stop intralipids, and now we are using a SMOF. It's a new formulation of lipid that is much gentle to the liver. Try to optimize central line care and prevent and treat cholestasis. What is intestinal failure associated liver disease? And this is something that I want you to become familiar with. This is a life-threatening complication of patients with intestinal failure. Severe cholestasis at the time of transplant or referral is a significant prognostic indicator of mortality and transplantation. We did this evaluation in about 100 of our patients several years ago, and we found that patients that have high bilirubin have an odds ratio of mortality of almost 9 compared with the patients that have lower bilirubin. And the odds ratio for needing transplant, it was close to 4 if the patient have high bilirubin at the time of referral. Then prevention of cholestasis is vital for intestinal rehabilitation. Early referral to a multidisciplinary team is the key to optimize the care for this patient. What are the factors associated with the intestinal failure? IFAL, prematurity. We know that anybody of us that take care of babies, once they start on TPN, 2-3 weeks, all of them are going to be jaundice, and it's expected. It's impossible to prevent. You can prevent further liver damage, but cholestasis is going to be there. Recurrent sepsis, what kind of lipid emulsion you use, how much enteral stimulation you give to this patient. Transfusions play a role in intestinal failure, recurrent surgeries and anesthesia, and medication. Most of these patients are receiving a polypharmacy. Then from all this, what we can tell is that there are few that we cannot change. Prematurity, when the baby is born, you have to deal with that. Transfusions, if they need it, they need to get it. Surgeries has to happen to save their life, and medication. Then there is no much that we can impact or change on that. But we can change this. We can change the recurrent sepsis. We can change the amount of lipid or what type of lipid we use. And also we can change how much and how we are going to stimulate their bowel. Recurrent sepsis, then line care prevention of sepsis. Teaching the family, most of our patients are home on home TPN. We need to teach the family how to care for that. We need to improve the line care in the hospital. We can use bactericidal barriers at the entrance of the Brobiac, and also we can use the antibiotic lock for prevention and treatment of infections. Ethanol lock is something that we have been using for many years. We use it to treat infection in the past. Many patients went to transplant because they lost access. The more lines you pull and replacing, and then a patient at a year old didn't have any line access. Now, when the patient comes, if they don't respond to the antibiotic right away, they get ethanol lock, and this was an evaluation that we did many years back. 90% of our patients were treated successful with the ethanol lock and the catheter was in place. Then the only problem with this, sometimes the catheter get occluded, but they can be treated with thrombolytic agents. Lipid emulsions, big topic. Then this is part of the study that we published a few years back. We organized the patients in 3 groups. Group 1 didn't have any cholestasis. Group 2 have a bilirubin of less than 15, and group 3 have bilirubin more than 15. When we stop the intralipids or minimize the intralipid, all the patients improve. Maybe not so much for group 3 because the liver was still very damaged, but at least you can make an impact and you can stop the progression of liver disease. Similar study was published by the UCLA people. They started lipid minimization in 2009. These are the gray bars. The black bars are the patients before 2009. And as you can see, more than 50% of the patients have a bilirubin more than 8 when they receive the normal intralipid dose. Once they start lipid minimization, the gray bar, you see more than 50% of the patient, the bilirubin was less than 4. Then this is definitely telling you that lipid minimization, mainly intralipid, the omega-6 containing lipids, is important. We have the studies published with omega-ben. This is mainly fish oil. This is omega-3 based lipids. Also, the green lines are the patients that stay on intralipids. The gray line is the patient that receives omega-ben. Significant improve on the bilirubin level for the patient that receives the omega-ben. Same publication study, a larger study. This is from the Boston group. Patient that receive omega-ben, significant decrease the cholestasis. Patient that stay in intralipid, the cholestasis stay progressive. Then here it comes SMOF, and this is maybe one of the few publications from SMOF. This is a new intralipid that is a combination of omega-6 and omega-3. And what they demonstrated is that for patients that receive SMOF, for patients that receive FMOF, the bilirubin decrease. This is the first line here. And for patients that receive intralipid, the bilirubin stay elevated. They also demonstrated that the patients stayed in the same amount of intralipid. There was no decrease in the dose of intralipids. Then what this tells us is that restricting the use of high dose of omega-6 containing lipids plays an important role in the prevention or improve of the intestinal failure, and the omega-3 containing lipids could be indicated in a selected group of patients. Keep in mind that if you give only omega-3, this patient will develop essential fatty acid deficiency. That is another complication. I don't have time to go over that today, but it's something that we have studied very thorough. Hormonal treatment. I think that this is the new thing. I think that this is the future for the treatment of this patient with intestinal failure. All these hormones are somehow made in the body and have to do with the intestinal health and intestinal adaptation. Pay attention to this glucagon-like peptide 2. This is mainly made in the terminal ileum, and this has been studied for many years. And this medication called teduglutide was developed. Is the glucagon-like peptide 2. The problem is the glucagon-like peptide 2 have a half-life of about 7 minutes in your body. Then you are constantly producing that. To make that on a medication is very difficult. Then they change an amino acid, and the half-life is about 2 hours. Still short. And this is what happened when you have this medication. This medication promotes repair and growth, reduce gastric emptying, increase fluids and nutrients, and stimulate. But the problem is also stimulate growth, polyps and cancer. Then for patients on this medication, they have to be in surveillance of colonoscopy because the polyps can grow really fast and they can develop cancer. There was a study in adult patients, and it was a very complicated study. I want you to focus just on this part. This is the adult study that got the approval for the FDA in the United States to use this medication. They used 3 groups, 1 placebo, 1 high dose, and 1 low dose. The high dose was 0.1 milligrams per kilo, and the low dose was 0.05 milligrams per kilo. The endpoint of this study was more than 20% reduction of parenteral nutrition volume. They are focusing in the volume of fluid at 20 to 24 weeks, and the lower dose achieved significant difference. The higher dose didn't. Then the one that is approved for the treatment is the lower dose. This is in adults. In pediatric patients, there was this first publication this past year. This was about 23 pediatric patients. We also make 3 groups. One group was a standard of care. We couldn't believe that we are going to give placebo injection to a pediatric patient. Then we make it a standard of care. They underwent the same surveillance that the other patients, and looking at the TPN reduction. Then again, for pediatric patients, we use 0.05 or 0.025. The lower dose also have higher significance, and most likely that is the dose that is going to be approved. What is the problem is a daily injection. The effects reverse after administration stop. Then you can get a patient off TPN, but if you stop giving the medication, the patient might require TPN again. Potential for tumor initiation and development then is something that we are concerned. And the cost, $300,000 per patient per year. Then this is a very expensive drug. Though taking care of this intestinal failure patient is very expensive. When they are on TPN, about $500,000 a year. Then what happened with the enteral feeds? How can we improve that? What are the optimal feeds that promote intestinal adaptation? We very frequent get asked the question, continuous feeding versus bolus feedings. Then really I think that the best will be a combination of both. Getting the patient to eat by mouth is important, but if the patient doesn't eat by mouth, we choose the tooth feeds. And also having continuous feeds help with the adaptation during the night. Surgical options, I'm going to talk basically about these two, the step procedure and the longitudinal intestinal lengthening that is called Bianchi. I'm going to present, this is 111 consecutive patients enrolled in an international database for a STEP. They are reporting the outcome of 87 patients that survive. And from these 87 patients that survive, 48 achieve intestinal autonomy. What is the difference? What is the difference between the patients that die and survive? And they look at all this data, but the really relevant data is that the patients that survive have lower bilirubin. Again, intestinal failure associated liver disease is the determining factor of this patient's survival. And the patient also that have a larger bowel, that might be a surrogate that the patient might be having less liver disease because they are being fed. Then when we look at the variables between the patients that came off TPN and the ones that didn't, the only variable that was significant is the bowel length, pre and post step. The key points: and autologous intestinal reconstruction should be performed to facilitate adaptation. The procedures should be tailored based on the functionality of the bowel, and best outcomes are achieved by a multidisciplinary approach at the Center of Excellence. In conclusion, management of pediatric patients with short bowels presents a challenge for physicians and other healthcare professionals. Remember, the most important thing for us is to keep the patient alive. Then immediate goals should be fluid and electrolyte balance, good nutritional status, and growth velocity. Remember, these are children. What they are supposed to do is growth and develop. If they cannot achieve that, it's going to be a problem. Then you need to give what this child came to us severely malnourished because the doctors were concerned that if they gave too many calories, and the father was, too many calories is not good because the liver gets destroyed. But then if you don't give enough calories and they don't grow, maybe you are not delivering the care appropriately. Appropriate and timely nutrition of parenteral nutrition to promote optimal intestinal adaptation is important. The supplementation of appropriate vitamins, minerals, and other nutrients is also important. And to really achieve enteral autonomy, that is the goal here, we should have an aggressive and timely medical, nutritional, and surgical intervention to prevent complications. That cannot be done by one person. That needs to be done by a multidisciplinary team. It's very time consuming to take care of these patients. A doctor doesn't have to be the one doing the day-to-day management. We have nurses, we have nurse practitioners, we have nutritionists that help us to do that, because otherwise it's impossible. I will say that the future is translational and clinical research to move forward to prospective multi-center randomized controlled trials. How we are going to determine which patient might do okay or which patient you might need to send early for intestinal transplant. You cannot do that based on 20 patients, even 200 patients. I think that we need thousands of patients to be able to do that. And that can be accomplished only by a multi-center, multinational register that we should be moving forward to. Cooperative protocol, if we know that one protocol is better than others, let's try everybody to embrace that protocol. And we should have some vision in the future to develop more humoral factors to promote adaptation. I think that teduglutide is the first of many to come. Then this is that patient. He came to us and he was this picture. In 5 weeks, this is what he was. And we knew he has tuftine enteropathy. Then this is a patient that we shouldn't aim for rehabilitation because he will very unlikely achieve enteral sufficient. Then he moved for intestinal transplant, and that picture on the lower end on the left is 3 months after intestinal transplant. After my intestinal transplant lecture, I give you a video of him after more recently. And this is a picture of the beautiful place where I work. And we have a pediatric intestinal rehabilitation clinic. We have a multidisciplinary also intestinal transplant program, and we will be happy to help with any patient or any coordination of care that you might need help with.